Is skeletal muscle relaxants. In this lecture, we will learn the physiology of skeletal muscle contraction, the classification of skeletal muscle relaxants, and the effects and uses of depolarizing neuromuscular blocking agents. So to start off with the physiology of skeletal muscle contraction, how does skeletal muscle contract? There are two types of motor neurons that regulate skeletal muscle excitability. The upper motor neuron originates from the cerebral cortex and the lower motor neuron arises in the spinal cord. The upper motor neuron innervates into the lower motor neuron, which in turn innervates into the skeletal muscle. Each alpha motor neuron innervates about 200 muscle fibers, forming a complex known as the motor unit. With movement, an action potential is generated and the action potential travels down the motor neuron, causing depolarization of the nerve terminal. As we can see here, the action potential travels down and causes depolarization of the nerve terminal, and this depolarization leads to opening of the voltage-gated calcium channels, allowing the entry of calcium into the nerve terminal. The calcium stimulates the release of acetylcholine, a neurotransmitter that is stored in the storage vesicles, into the synaptic cleft. The acetylcholine that is released into the synaptic cleft binds with the nicotinic receptors of the motor end plate, particularly the NM receptors of the motor end plate, causing a conformational change in the receptor. The conformational change in the receptor opens the voltage-gated sodium channels, allowing the entry of sodium ions and causing depolarization of the muscle fiber membrane. So this depolarization of the muscle fiber membrane spreads to the sarcoplasmic reticulum through the T tubules, and this stimulates the opening of the calcium release channel, also known as the ryanodine receptor. So the calcium that is released into the cytoplasm of the muscle membrane combines with troponin C, and this exposes the myosin binding sites, and since the myosin binding sites are exposed, the actin forms a cross-link with the myosin filaments, and this facilitates the contraction of the skeletal muscle. So this is the pathway that is responsible for skeletal muscle contraction. So what is a muscle relaxant? A muscle relaxant is a drug that affects the skeletal muscle function, causing relaxation. The skeletal muscle relaxants are classified as spasmolytics and neuromuscular blocking agents. The spasmolytics, as the name itself implies, it reduces the increased muscle tone to normal. Increased muscle tone is observed in lesions of the upper motor neuron caused by cerebral palsy, multiple sclerosis, poliomyelitis, spinal cord injuries, and traumatic brain injuries. So these lesions can cause spasticity, which is characterized by increased stiffness and increase in the muscle tone. So spasmolytics include anti-spasticity medications that reduce spasticity, that help to reduce the muscle tone to normal. These drugs include baclofen, tizanidine, gabapentin, pregabalin, chlorzoxazone, cyclobenzapyridine, and carisoprodol. So these anti-spasticity medications produce their effects by acting in the central nervous system. Spasmolytics can also act in the periphery. For example, dantrolene is a drug that acts directly in the muscle and produces relaxant effect. The next category of skeletal muscle relaxants are the neuromuscular blocking agents. So these are the drugs that interfere with the neuromuscular transmission at the motor end plate. So they reduce the neuromuscular transmission at the neuromuscular junction and cause skeletal muscle relaxants. They can be classified as non-depolarizing neuromuscular agents and depolarizing neuromuscular agents. The non-depolarizing neuromuscular agents can be classified based on the duration of action. For example, short-acting drug is mivacurium. The intermediate-acting drug is vecuronium and rocuronium. Long-acting drugs are pancuronium and pipecuronium. Amongst the depolarizing neuromuscular blocking agent, succinylcholine is the most commonly used depolarizing neuromuscular blocking agent. So in this lecture, we will be focusing our talk on the effects and uses of succinylcholine, which is a depolarizing neuromuscular blocking agent. Depolarizing neuromuscular blocking agents. Succinylcholine is the most commonly used depolarizing neuromuscular blocking agent. It is used for rapid sequence induction of skeletal muscle paralysis. Administered at a dose of 1 mg per kilogram, it initially causes twitchings and fasciculations on the chest and abdomen, which spreads rapidly to the neck and the limbs and causing complete paralysis of the skeletal muscles. So succinylcholine has a rapid onset of effect, a shorter duration of action and profound depth of neuromuscular relaxation. So the effect appears within 1 to 2 minutes and disappears in 5 to 10 minutes. So for longer effects, succinylcholine must be given by IV infusion. Succinylcholine is commonly used to facilitate endotracheal tube intubation, facilitate minor surgical procedures and aid mechanical ventilation. So let's now move on to the mechanism of action of succinylcholine. Succinylcholine is an acetylcholine analog. So how does succinylcholine act as a skeletal muscle relaxant? Succinylcholine is an acetylcholine analog. The underlying mechanism of action is similar to that of acetylcholine in that it directly stimulates the NM receptors of the motor end plate, causing depolarization of the muscle membrane. But unlike acetylcholine, it has a longer duration of action of 5 to 10 minutes in comparison to acetylcholine, which is rapidly hydrolyzed and has a duration of action of few milliseconds. So the longer duration of action of succinylcholine is because it is hydrolyzed by pseudocholinesterase enzyme and therefore succinylcholine is slowly hydrolyzed by the enzyme, and this causes a longer duration of action of succinylcholine. It persists in the synaptic cleft for a longer period compared to acetylcholine, which is rapidly degraded by the true acetylcholinesterase enzyme. So because of the longer duration of action of succinylcholine, it causes depolarization for a longer period, which in turn leads to flaccid paralysis and the blockade of neuromuscular transmission. The initial neuromuscular effect of succinylcholine is that it causes twitchings and fasciculation on the chest and abdomen. This is due to the discharge of impulses directly into the muscle fiber, causing depolarization and excitability of the muscle fibers, and this causes twitchings. So the depolarization continues because of the longer duration of action of succinylcholine. Because succinylcholine persists in the synaptic cleft for a longer period, it causes persistent depolarization in the absence of repolarization. Although acetylcholine is freshly released from the nerve terminal and stimulates the motor nerve fibers at the nicotinic receptors, the motor end plate is unresponsive to the incoming depolarizing signals of acetylcholine because the motor end plate is desensitized, and this phase is known as desensitization phase. In this phase, flaccid paralysis continues, there is blockade of neuromuscular transmission, and the motor end plate is unresponsive to the signals. This is also known as phase 1 block. At higher concentration, succinylcholine converts the phase 1 block to phase 2 block. The phase 1 block is the depolarizing block, whereas the phase 2 block is non-depolarizing block. So to sum up the neuromuscular effects of succinylcholine, initially twitchings and fasciculations are seen, and this is due to the stimulation of the muscle fibers causing excitation. The depolarization continues because of the longer effect of succinylcholine, and persistent depolarization in the absence of repolarization causes blockade of neuromuscular transmission and onset of flaccid paralysis. The flaccid paralysis continues till the membrane is once again repolarized and is ready for excitation. In this phase, the motor end plate is unresponsive to the incoming depolarizing signals of acetylcholine that are freshly released by the nerve terminals. And at higher concentration, the phase 1 block is converted to phase 2 block. So succinylcholine produces dual block, that is phase 1 and also phase 2 block at higher concentrations. So these are the neuromuscular effects of succinylcholine. The other effects of succinylcholine are cardiovascular effects. The initial effect of succinylcholine is that it stimulates the vagal ganglia, causing hypotension and bradycardia, and subsequently this is followed by hypertension and tachycardia due to stimulation of sympathetic ganglia. So let's now move on to the adverse effects of succinylcholine. Succinylcholine can cause hyperkalemia. This is due to efflux of intracellular potassium into the plasma during depolarizing blockade. So this causes a rise in plasma potassium level. This is not of much clinical significance in a normal individual, but cases of burns, uremia or spinal injury are susceptible to hyperkalemia, and this can precipitate arrhythmias and can also lead to cardiac death. The increased susceptibility to hyperkalemia in such individuals is due to supersensitivity or upregulation of the acetylcholine receptors in the muscle membrane, and this causes spreading of the depolarization across the muscle membrane, causing increased release of potassium into the plasma, leading to hyperkalemic rhabdomyolysis, and this precipitates cardiac arrhythmias, ventricular arrhythmias, and can also lead to cardiac arrest. Therefore, succinylcholine should be avoided in such cases. The next adverse effect is malignant hyperthermia. It is an autosomal dominant condition in which there is mutation of the ryanodine receptor or the calcium release channel of the sarcoplasmic reticulum, causing uncontrolled release of calcium into the cytoplasm of the muscle fiber. Increased release of calcium causes persistent contraction of the skeletal muscle, causing muscle rigidity. This is accompanied by massive metabolic reaction. Due to aerobic and glycolytic metabolism, there is increased heat production, and this causes hyperthermia, tachycardia, tachypnea, increased carbon dioxide production, increased oxygen consumption, muscle rigidity, and very high temperature. Malignant hypothermia can be precipitated when a general anesthetic such as halothane is combined with succinylcholine, and this triggers the onset of malignant hyperthermia. The next side effect is masseter muscle rigidity, and this occurs due to mutation of the voltage-sensitive sodium channel, and this can complicate endotracheal intubation associated with the use of succinylcholine. But prolonged apnea may be associated with use of succinylcholine in some individuals, as we have learned that succinylcholine is hydrolyzed by pseudocholinesterase enzyme, and the duration of action is 5 to 10 minutes when administered at a dose of 1 milligram per kilogram. But in some individuals, there is an abnormal pseudocholinesterase enzyme, which is also known as atypical pseudocholinesterase enzyme. Because the pseudocholinesterase enzyme is abnormal, there is further slowing of the hydrolysis of succinylcholine, leading to a prolonged duration of action of succinylcholine, and this causes paralysis of the respiratory muscles, causing prolonged apnea. There can also be quantitative deficiencies in pseudocholinesterase enzyme, for example, in old age, collagen vascular diseases, liver diseases, where because of the deficiency of pseudocholinesterase enzyme, the action of succinylcholine is prolonged, and this can lead to prolongation of apnea. The next side effect is increased intragastric pressure, and this is due to fasciculation and can cause nausea and vomiting. Increased intraocular pressure can also occur with succinylcholine use, and this is due to tonic contraction of the myofibrils of extraocular muscles of the eye. This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.